Hi to the Nurse Break. Thank you for this opportunity to speak about being an oncology nurse practitioner. My name's Marisa. I've been a registered nurse for 20-ish years. An oncology nurse practitioner is someone who specialises in the field of oncology, so working with cancer patients and specifically with patients with solid tumours. And probably in the last few years, I've probably narrowed it down to really focusing on breast cancer patients, both early breast cancer patients and those with advanced disease. A nurse practitioner is someone who has completed their masters, and to be accepted to do your masters to become a nurse practitioner, you need to have X amount of years working in a specialty to be accepted into the course. Nurse practitioner is someone who can work independently. We work in collaborative care with the medical team, with other doctors, but I can order scripts, I can order scans, I can refer to other medical professionals, and I can bulk bill in or charge in my practice as well. I started out actually in orthopedics when I did my grad year a long time ago, and I did 6 months on an orthopedics ward and I hated it. It wasn't for me. And then I moved into oncology, and I think I was just lucky. I was sort of interested in that area, but I didn't really have a calling for it or anything like that. I landed in a really good team, I think, and there was a wealth of experience. Everyone was very keen to learn, everyone was keen to teach. My mentor was amazing, she really pushed me, and I did as much as I could in that 6 months. So I learned to cannulate, I did chemotherapy competencies, I learned to put catheters in, I learned about pain control. What else did I learn? Nicky pumps. It was sort of every end of life care was sort of thrown in this 6 months, and I stayed there for a couple of years after that. And then I did the inevitable travel overseas, and I was lucky enough to then land in a day oncology unit while I was over there. And I worked as a, I guess, permanent casual for 2 years in a day unit. So I got great rates because I could cannulate, I got paid really well. And because I was technically casual, I could take time off and travel. So it was a brilliant, brilliant opportunity. And I really encourage you to travel overseas if you can, because that's one of the beauties of being a nurse. So I got a real taste of day unit work, doing a lot of therapies for outpatients. When I came back, I started doing some short courses. So I landed a job in a day unit again, and I did my breast cancer nurse course during that time, and a lung cancer nurse course. I moved up to Queensland and I worked in a couple of different day units and on the wards, still in oncology at that time. And I think I just used that time to do a lot of short courses. I never was really interested in going to uni and doing doing study. I think I was offered my honours after my grad year, but I didn't think it was going to get me anything. It was just sort of, for me, a bit of a waste of time. So I did short courses to try and get a feel for what I wanted to do. I did a bit of management in day units for a while, and I was thrown, when I was an ANUM, they threw me the quality folder, and I was like, oh, quality, doing audits and all that sort of stuff. But it actually paid off because while I was doing that, I really learnt that patient care was my focus, and I found a lot of gaps for our patients in the private system. So there was no one following these patients up. They weren't getting education before they came in for their treatment. No one was sort of overseeing allied health referrals. There was no continuity of care at this time. So I used my quality hat to do some research, survey patients, survey doctors, get some data on nurses triaging these patients and what an impact they can make. And so then I put a business case in to do basically a care coordinator role in the private sector. And I was lucky enough, I got some drug company funding as well as the hospital to do a 12-month trial of this role. And we called it a liaison role, and it got through, and then it just sort of grew from there. And then I guess the hospital I was at wasn't really open to nurse practitioner roles at the time. And then another hospital said that they would support me doing that. So I switched hospitals because they were supporting me become a nurse practitioner. I got some sponsorship, but also having the hospital support me meant I could take a lot of study leave and fiddle my hours so I could do the study that I needed to do. In terms of my qualifications, I didn't do sort of a postgrad. All my short courses and my experience were enough to get me into the master's program. I was terrified about going back to uni. I hadn't been for a long time, and so going back as an adult learner was incredibly hard, and your brain just doesn't work as what it used to when you were younger. So it was hard, but it was great. And so 2 years it took me to do my master's through Melbourne Uni. And so now I've been a nurse practitioner for a couple of years, and I'm still, learning about the role. So the type of patients that I look after now, as I said earlier, mainly breast cancer patients. And so there's one group which is the adjuvant, so the early breast cancer, the curative patients. So I educate them about their treatment. I follow them up throughout their treatment. They can call me if they have any problems, do a lot of patient triage if they're unwell, ensure allied health referrals are in place, survivorship education. I see patients in the day unit, see patients that are admitted to the ward. So I'm sort of their key person, their key contact person. And then I also look after patients with metastatic or advanced disease. And that's patients that are on oral therapies and IV therapies. So I guess the beauty of looking after both groups is that you build up great relationships, and unfortunately there are always patients in the early breast cancer patient group that do have relapse disease years later, and it's a nice thing for them to remember that nurse that's still there, because you can pick up that relationship straight away and that trust is there. A typical day looks like I start very early, about 6:30, and that gives me time to chase up bloods, prep for the day, make sure everything's ready to go, then do ward round if we have any inpatients, and then we start consulting from 8 o'clock because the day unit opens at 8 o'clock. So I do a lot of collaborative consults with the medical oncologist. So that might be my morning, seeing all those patients coming in for treatment who are on oral or IV therapies. And then I may have some patient consults in the afternoon of new patients coming through. And this is where I'd spend about an hour with them, reiterating about making sure they understand their diagnosis, the goal of care, what their treatment involves, assessing their sort of social situation, what allied health do I need. Most importantly, coming up with a game plan for these patients. How do they manage this whole new world their world's been thrown upside down? They've got to have chemotherapy, they've got kids, they've got a job, financially, transport, etc., etc. So it's trying to give them some good strategies to get through it, basically, and be proactive and be invested in their care. I get a lot of incoming calls, and obviously if patients are unwell, you get a lot of unplanned admissions as well. But my job, I guess, is trying to follow up patients and trying to intervene early so that we keep them out of hospital if possible, but equally we can admit them very quickly if they need urgent care. Myths and misconceptions about oncology is that it's a really sad area to work in. I'd be lying if I said it wasn't hard at times. There are certain patients that get under your skin and some patients that progress incredibly rapidly and it feels like we can't do anything to help. But majority of the time, I think for end of life, it's coming, so you can prepare for that. It's not a surprise. And so your job or my job is to help the family and help the patient get through that time and understand end of life care or whatever it may be. So that's an incredible privilege, I think. I don't really see it as depressing. It's part of life. So, and a majority of the time, you build up great relationships with these patients, and patients are just people, they're your friends, your family, and they're great people, and we have a laugh, and it's majority of the time it's great. So I think that's the biggest misconception, that it's depressing. Yes, it's hard work mentally and emotionally, but it's an satisfying job. I think you make a real impact on people's lives. The positives of my clinical area, I think, the diverse nature of skill that you need in this job. So there's the skill-based, as in cannulating, accessing CVADs, NICU pumps, catheters, all that kind of stuff. There's the understanding of drugs, because there is a lot of drugs in oncology. So the chemotherapies, the pain medication, the antiemetics, etc., etc. There's end-of-life care. There's education. There's family. There's working with staff and educating staff. So I think it's a really good diverse area to work in. The challenges of working in my area is there's probably never enough time, and in the private sector, resources probably aren't as good as in the public. So there's a lot of pressure on, I guess, nurses to sort everything out and try and access things that are not as easy to access. I think if you were considering going into oncology, what are the tips? I'm trying to think. One of the best tips when I was working on the ward as a grad was, because I was sort of overwhelmed and there's all these treatments and who gets what treatment and all these different types of chemotherapies. And I remember my nurse unit manager saying, pick a patient and follow that patient through from the beginning. Look back to their diagnosis. What have they come in for? What are all their treatments? And when they're having a treatment, think about that person and what side effects they're getting, because that then helps you learn about the chemotherapy that they're having. So I found that really helpful. I think having a good mentor is just, whichever area, whether it's oncology or whatever, having a good mentor is so important. Someone who's going to challenge you is important. Someone who's going to give you a lot of opportunities. I was given so many opportunities and I just ran with them. So I think in that grad year, when you have that support, go with it. Just learn as much as you can and push yourself, because once you get out and you're not a grad anymore, suddenly you're on your own, and all that education falls on you to do. You've got to push yourself and work out your own path. But when you're a grad, you've got that support, so use it. 10 years from now, I hope for nurse practitioners, I hope we are very much established and recognised, and perhaps don't have to be in collaborative care with doctors to be able to work. I think we nurse practitioners particularly fill a gap. Clinical nurse specialists fill a gap. The oncologist job, I guess, is to treat the cancer. And I see my role very much as quality of life, making sure that side effects are being managed well, their day-to-day functioning is being managed well, that they can manage at home, that they have contacts. I very much think that the nurses are the quality of life, and we see patients more than doctors. We spend a hell of a lot more time with them than doctors. So we know the patient, and I think we're a good advocate for the patient. And we should be partaking in medical decision making, because we know what the patient can manage and can't manage, or what the patients disclose to you that they may not have disclosed to the doctor. So I think, don't underestimate your role and your importance, and what you offer to that patient's care. What I've learned through my career, I think you've got to make your own opportunities. I put a business case in because I saw a gap, and I worked hard at doing that, and that has opened up a lot of opportunities. I've learned from the people I've needed to learn from. I've picked their brains. I've got involved in things. I think, I've thrown myself into things when I was shit scared, and I sometimes it wasn't what I wanted to do, but I then learned that that's not what I wanted to do, and it helped me narrow down, that I wanted to be involved in patient care, and that's what I was good at. You've got to do your own education a bit, I think. It's not going to be handed to you, particularly in certain sectors of hospitals. You've got to go out and look for it, and sometimes you've got to pay for it yourself, and so be it. But if you know where you want to head, then work for it. And, you know, if you've got education support at the hospital, then use it. It's there to be used. So yeah, create your own opportunities, I think, is really important. So look, oncology is a really great area. It's constantly changing. It's quite dynamic. If you like people, which I hope you do as a nurse, you do build up good relationships. And, you know, part of what I do is building up relationships and having that trust, so the patients contact me and then I can help them. It's been a bit waffly, but I hope that it might have helped a little bit. I'm more than happy if you want to email me and get in contact with me if you want to find out any more. So my email address is Marisa, Marisa.Stevens with a V at svha.org.au. So thanks, Jackson, for putting this together, and I hope it's been helpful for someone. Thanks.